So, welcome everybody. This is the last session for the year. We'll be back again in the fall, but it's a real pleasure for me to welcome Wendy Epstein and Chris Robertson from respectively DePaul and BU Law Schools. They're going to be talking about their recent work that appeared in the Journal of Legal Studies about sort of the role of sociality in promoting insurance enrollment. And in a way, as I was telling them just before we went on the air, it's very fitting that we're ending the semester with people talking about this, because the semester began, if you may remember, with Elizabeth Anderson, the philosopher, talking about these same questions 300 years ago in debates in sort of English welfare policy. And so it's kind of coming full circle to see how people might be motivated by things other than self-interest, and how we can use that, exploit that sort of psychological characteristic to increase enrollment in health insurance. Before I turn it over to Wendy and Chris, just a few short business announcements. Travis Pentine was very sorry. He had a last-minute family sort of emergency that he had to take care of, so he's not going to be able to be here, but he asked me to apologize for his absence. The second thing is, as I said, we'll be back in the fall. If you know anybody you think we should be hearing from, or if you are a person who wants to be heard, please contact me or Travis, and we'd be delighted to consider that. And then finally, I want to give special thanks to the people who've worked behind the scenes all semester to make this all possible. That includes Quentin Brooks, who takes care of all the tech stuff, and Maggie Marolo and Jean LeBlanc, who take care of all the registration and notification stuff. We couldn't have done without you, and we're all very grateful. Okay, so Chris and Wendy, you've got the floor for as long as you want, roughly 40 minutes, and then I'll take the questions afterwards. Thanks again for coming, and we look forward to hearing from you.
Oh, thank you so much, Peter. Hello from Boston. It's a sunny, warmish day here. And I have Wendy. I want you to make sure we can hear you as well.
Here. Hello from actually Philadelphia at the moment.
So Wendy and I have been collaborating on this series of research projects. You can say it says 5 phases, but really phase 0 is really a paper of Wendy's that I'll talk about in a moment. We have not really planned how we're going to split up this presentation, wanting to keep it a little more organic, so we'll be jumping in wherever. In addition to the two of us, this is part of a larger research team, including Hansu Ko, and Kevin Wilson, who are the quant guys doing all the stats in the background, as well as David Yoakum and Monica Ramos. And this is all funded by the Robert Wood Johnson Foundation Evidence for Action program, which we gratefully acknowledge. They've really been working with us now for 4 years or so through revise and resubmits and guidance along the way, in addition to the financial support. So it really does come to this fundamental research question of whether we can use moral framing to improve health insurance uptake. And the motivation, of course, will be familiar to everyone on this Zoom or webinar, that people who lack health insurance have all sorts of problems with accessing health care. They're not able to have a usual source of care. They postpone care. They go without care when they need it. They delay filling prescriptions. And a body of research has also shown that this starts to have health outcomes. When you ask people, why aren't you insured? So this is just among the people that are not covered by health insurance in a 2019 survey. About 3/4 say, well, I actually just couldn't afford it. Health insurance is too expensive for me. And I do want to mention that a lot of the follow-up surveys, if you ask them, have you actually priced an insurance plan for yourself? The vast majority say, no, I haven't recently done so. So in fact, they may not realize they're eligible for all sorts of subsidies and things that they didn't realize. But we're really, even putting that aside, 26% of the uninsured is still a huge population. And so we are sort of interested in why they're not buying health insurance if they can't afford it. And so this really breaks down to 2 clusters of reasons or non-reasons. There's some that we could label as rational thinking, exploiting private information. I know that I am peculiarly low risk, which insurance people call adverse selection. We also know there's externalities here, and that EMTALA, for example, a federal law in the health insurance space, allows you to get health care without hospitals asking if you can pay through emergency rooms. But there are also some what you might call irrational or irrational factors, what you might call, biases or heuristics. Some people are present biased. They're just focused on their current health, and they have trouble imagining the long-term future. And even when they do imagine it, research shows they're often optimistic, like, oh, I'll be better than the average person in my health. we know a wealth, but of that sort of research. Putting these together, it's just that insurance is a bad deal for me. Whether I believe it rationally or irrationally, I just don't see it as a good value proposition. And so the historic sort of policy approaches that we work on every day in law schools is carrots and sticks. You can incentivize people. You can somehow give them even more subsidies or other benefits, like throw in a gym club membership to insurance or whatever else. Or sticks. You can mandate it and penalize them if they don't get it. And of course, there's examples of both in our health policy today. The affordable mandate, though, was repealed, the federal one, of course, although now I think over 6 states, I think about 6 states have state level mandates. But putting those two approaches aside, we're really interested in a third one, is whether framing the health insurance purchase decision can change behavior. So this really relates back to a paper that Wendy wrote in 2020 as the mandate was getting punched and punched and punched by court decision after court decision and then by Congress zeroing it out. Wendy wrote this really compelling paper suggesting we could use some insights from behavioral economics, from the nudge literature, to get people to buy health insurance even if it's not mandated. And so she and I were having a conversation at a conference, and I was like, those are all empirical questions. She's like, they sure are. And so we got to work over the last 3+ years in testing those questions. So that really motivates this question. Is insurance best framed as a consumer choice, where you're trying to figure out if it's a good deal or a bad deal? Or could there be other framings, moral framings, like helping others, serving your community, being responsible? And we know that word, especially in a public health context, is sensitive. But we think that there may be a possibility of leveraging the deep political commitments that have developed over recent years. You'll recall, even as Republicans were campaigning to repeal the individual mandate, they said, but we're going to protect pre-existing conditions. And the health policy nerds were, well, those are two sides of the same coin. But the Americans, even here, you can see over half of Republicans back in 2018 said, I think we should protect pre-existing conditions. They're expressing a moral commitment to even people that are ill among Americans. And so can we leverage that same insight for consumer behavior? You actually buy insurance. Vote with your feet if you think that's so important. Wendy, anything you'd like to add at this point? I kind of went through all that with my spiel.
No, I think you're doing a great job. Let me just add one thing on this slide, which is that implicit in the way that the Affordable Care Act is structured, in order for insurance companies to be able to afford to cover sicker people in the population or older people in the population and not charge them significantly higher rates, is this commitment of younger, healthier people to purchase insurance to subsidize the cost of those more expensive folks. And so, as Chris and I were sort of talking about this and we were looking at this survey data, we were thinking to ourselves, kind of odd that we're telling, especially young and healthy people, like the reason to buy health insurance is because it's a good deal, or, this is a rational economic choice. But some of them correctly are surmising that, it's not actually a great deal for them, but we nonetheless want them to purchase health insurance because we need them to even out the cost of the more expensive folks. So if they, if these surveys are accurate and people have a commitment to wanting the more expensive folks to be able to get covered at a reasonable rate, then maybe we could just be honest about it and say, hey, it's a generous thing to do. It's an altruistic thing to do. It's, helping your community to get health insurance rather than it's a rational economic choice.
Can I just quickly ask, I mean, I'm with you 99% of the way on almost everything you said, but I'm not sure I see that this really suggests there's a strong moral framing at work. I believe that there is, and your results show that. I mean, it could just be that I think, first of all, many people just don't understand how this all works. But second of all, I may develop a pre-existing condition even though I don't have one now. So it could be very selfish. I'm thinking, well, I might need this later for myself. And you're certainly not highlighting here the cross-subsidy point that I'm willing to pay more than my fair share in order to help somebody else who has to pay too much for their fair share. So I'm just not sure that this is really strong moral evidence as much as your paper certainly is.
Yeah, this is more the motivation. Now we're going to take that next step to see if we can translate that into consumer behavior. Exactly right. So the project we set out to do ends up with 5 stages, including measuring status quo approaches, a pilot experiment, focus groups we'll skip, an advertising field experiment we'll talk about in more depth, and then a field study with exchange partners. And so diving into, first of all, phase 1, we just want to show what marketing for health insurance looks like today. And so we downloaded about 5,000 advertisements that are actually used on the internet to sell health insurance. We recruited 2 very conscientious research assistants to go through them, or at least a sample of them, and actually code. Does this one speak to a moral theme, or does this one speak to affordability or coverage? And that affordability coverage really is that rational actor idea. This is a good idea for you. Now, some of them really are just devoid of content. They're just like the deadline to enroll is coming up. So that's none of these themes. But of the ones that have a theme, we found that 96% of them spoke to that normal rational actor consumerist model. And really, we're not trying to invoke any of these moral themes. So that's where we see, hey, here's an opportunity to see if something new will work.
There's just one clarification on that. The sample of ads that we pulled was advertising that was either done by healthcare.gov, the federal exchange, or by the state level exchanges. So this was all, ACA marketplace advertising.
Great. So let's drill into this little pilot experiment we ran as a vignette survey experiment, really to kind of motivate and clarify our ideas about how you would break into this space. And for this purpose, we recruited 551 people who were uninsured from an online panel. So we pre-screened them twice to make sure that they said they were uninsured. And then we presented a kind of a rich, detailed health insurance plan with explaining the coverage network and the cost sharing profile. And we even tried to adjust the premium based on their age and income, as the Affordable Care Act would do. And then we just asked them, how likely would you be to buy this health insurance plan? But then we manipulated it in a few different ways. First of all, we had just the base case as I've described it. In another one, we tested one of Wendy's sort of novel health insurance reform proposals that would actually have a rebate feature for people. If you don't use health insurance, then you could get a little money back each year. We also tested the idea of a long-term plan, like the way a cell phone contract might ask you to sign a 2-year plan, or a mortgage insurance rate would only adjust after 5 years. The idea, if we can bind people into the plan, we can offer them a lower teaser introductory rate. And then we also tested this moral frame, and particularly around generosity. And we wanted to sort of be able to calibrate, if we saw any differences, how would it compare to just giving people another $500, lowering the price as a subsidy? So that sort of allows us to calibrate any effects that we see. And here's what we found. I've highlighted the 2 main plans here. That the base case, about 42% of the people said they'd buy the insurance. In the generosity case, that goes up to 52%. That's a 10 percentage point difference, almost a 25% relative change. Wow, that seems to be helpful, at least. Whereas we actually saw that offering long-term plans, at least the way we described them in this pilot study, hurt a little bit compared to a base plan. A return of premium may have helped a little bit, so there's a research agenda for a future study. And offering a $500 subsidy, it's statistically indistinguishable from the base case, but it sure didn't help. Just giving people more carrots was not enough to move them to be more likely to buy. So we found this pilot data at least to motivate the next, 3 years of research that we've been doing. Okay, so that then drove us into what gets to be more exciting. We did do several focus groups in both Spanish and English as we started trying to refine, okay, what would a moral framing look like? How should we express it? What resonates with people? What doesn't? And so this was part of our, you could also describe that as user experience testing. We were trying out our ideas with focus group respondents. And that really allowed us to then tailor our approach in the advertising field experiment. So for the advertising study, we went to Google and we gave them $34,000 of RWJ's money and designed a campaign to target. Another over $10,000 was spent with an ad agency advising us on how to do this and where to place the ads. And turns out it's kind of complicated to advertise insurance, in particular health insurance, because of some regulatory sensitivities. But anyway, we were able to measure how often the Google users would actually click on the ad, and the ad said, "Shop now for health insurance" was the button to click. So we were observing an actual consumer behavior, not just an intention. They wanted to shop for insurance based on what our ad said. And we were able to observe information about them individually. You may not realize this, but Google knows your age, Google knows your gender, Google knows even your household income and parental status for several for a lot of people. And so Google gave us all that information, otherwise de-identified. And so we created 4 different ad groups. One is this control group, speaking to the classic affordability and protection themes. And then 3 other treatments that resonated with moral themes: helping others who are sick, helping the community as a whole, or personal responsibility. And I'll show you some examples of what all those actually look like. Within each ad group, we let Google sort of optimize which one would be shown most often. So it ends up kind of like a tournament within each ad group. So we don't have to pre-specify, know which ad's going to be most effective. So within the group, it's a tournament. And then between groups, we can compare which group is most effective. And so this is an example of the actual ad. They call these ad assets. Each ad had a headline and a description, and Google would mix and match them to see which was most effective. So you might see an ad that says, "Be generous, get covered," and then the description is, "Buy health insurance." It means that someone else who's sick can afford a plan too. And so you can see all those speak on the right, speak to helping others, and all those on the left speak to affordability and coverage. And here's the next 2 treatments. These speak to helping community and responsibility. And the ones with asterisks at the top were the ones that Google found were the most effective. For example, under responsibility, "Be responsible, get covered. As you fight the pandemic, it's your responsibility to get health insurance coverage." So this was back in 2020, and some of those pandemic themes seem to resonate pretty well. You'll notice in other ways we try to keep them parallel. We actually rewrote each ad as sort of a ghost of the other ads and the other conditions. So the same length, they pick up the same secondary themes. So like the pandemic is reflected in some of the other groups as well. Anything to add so far, Wendy? Okay. So here are our big results. Because this is a true randomized experiment, you can actually just look directly at the behavior, the averages or the percentages in each group. You don't have to run any fancy statistical models, which is actually reassuring that you don't have to worry that we hacked the models. It's just like the data speaks for itself. So what you can see here is we ran the ads separately in English and Spanish. We ended up with about 3 million English ads and 2.6 million Spanish ads. And Google again knows which language you prefer, so it feeds you the ads that are based on your browser. These are all just in the United States, though, I should say. So we have huge statistical power then to detect effects, and that's important because click rates are actually quite low on the internet. People only click on about 0.5% to 1.5% of the ads that they see, and our ads actually perform pretty well compared to status quo ads out in the world. So what you can see here is the for English in that second row, the self-oriented ads perform the worst of all of the groups. They perform worse than helping community, helping others, or responsibility. In Spanish, on the other hand, you can see that the self-oriented ads did better than helping others or responsibility, but worse than helping community. So to summarize all that, the status quo approach was not the best approach for either English or Spanish. Okay, so we can also then do some fancy statistics to see if this is statistically significant, and I can give you a graph that's prettier to look at over on the right. These are the and essentially the same thing I just told you, though, but I do like to show you the raw data that speaks for itself. In English, self-oriented is dominated by all the other approaches, and in Spanish, the red group, the self-oriented approach is dominated by helping community. So we're seeing a little difference in how Spanish versus English speakers respond to these moral frames. So now just looking at the English group, we're able to disaggregate the effects by different zip code characteristics of where the respondents are when they see the ads. So you can see here the red line would be a null result, but you're seeing that in the English ads groups, personal responsibility is just dominating across all these different demographic groups, whether they're Republicans towards the bottom or Democrats 3 rows up, or whether there's lots of people who are uninsured or incomes are high or Hispanic share is high. That personal responsibility frame, all of those coefficients significantly different than the base status quo ads. Again, this is comparing people who got a status quo ad versus people who got a responsibility ad.
Before you flip, can I just jump in on that for 1 second, Chris? So we did have some hypotheses when we started this phase of the experiment as to what characteristics might make people more likely to click on a personal responsibility ad versus a helping community ad and whatnot. So we're a little bit disappointed actually when we ran this analysis and saw that kind of across the board, across all of these characteristics, you know, in zip codes that had a very low percentage of Hispanic residents, or in zip codes that had a very high percentage, that personal responsibility performed, you know, basically equally as well. Or you know, we had a theory that perhaps in more red states, politically leaning personal responsibility might be more effective. There may be higher click-through rates than in blue states, but we're actually, you know, not seeing that, at least in this phase. And so, you know, we can maybe talk in the Q&A about why that is, but everything's sort of lining up here regardless of characteristic.
And we have some other figures that look like this one, that look at individual characteristics like respondents' age, we look in the Spanish population as well. But we've decided to just show you a subset here. But one thing to call out, following on Wendy's point, is look how in this 4th row down, the Hispanic share high. I've already showed you that Spanish speakers are more responsive to the helping community frame and not so much the personal responsibility frame. But English speakers in high Hispanic share zip codes don't seem to have that same pattern. So whatever the cultural effect is happening there, it doesn't seem to cross over your browser's language use, at least. So fascinating and a little perplexing. Okay, so we did want to sort of try to quantify what our results would look like for a real world health insurer. And what we're able to show is that for every $1,000 you spend, if you'll just change some of the words you put on your ads, we're going to assume you're going to do some internet advertising anyway. If you'll just change some of the words, you can get an extra 35 people to shop now for health insurance per $1,000. And if you have say $100 million advertising budget, which the federal exchanges had in 2018, for example, that extra 100, shifting those words can actually cause 3.5 million people to shop for health insurance that otherwise wouldn't. And so we think this is a sort of an actionable intervention. It's by no means a solution to uninsurance in the USA, but it's a free win, essentially, if you're going to do some advertising anyway. You might as well get the words right. Okay, so this really pivots us to our 5th study. And the exciting thing about that Google Ads experiment is we were seeing consumer behavior to click on an ad to shop now for insurance, but we couldn't tell if they actually bought the health insurance for their data set. We've learned a lot through this process, but one of the things is that even health insurance exchanges don't always have the data connections that would allow them to track a person from a Google ad through their own health insurance exchange and then see how someone behaved in the system. So, you know, if you're Amazon's trying to sell, you know, shampoo, or if you're, you know, Zappos trying to sell shoes, this is just a basic function of the internet. But it's something that state agencies don't all have, or at least they weren't able to share with us their ability to do that work. So we're learning a lot here about how some of this goes in practice. So we did spend several more years talking with health insurance state exchanges about our findings in preliminary form and saying, hey, would you like to actually try this in your own marketing? You know, our prior study was in some ways like a guerrilla study in that we just flew in and started advertising to people and sending them to healthcare.gov. where here would like to actually work with an exchange so we can see what difference it makes. But even these exchanges said, well, we wouldn't be able to track from Google, but we could do a mailing, or postcards, or we could do an email perhaps, and then track those names to see if those people later sign up for insurance. We went through a lot of back and forth with several states who, in good faith, are working with us to see what would be feasible. I can't tell you how difficult it turned out to be, whether it's politically or technologically or just in terms of administrative bandwidth, to get these agencies to be able to collaborate. And two, Colorado and Maryland really stepped up and were incredibly appreciative of their working with us to test this research. So working with these two state partners, we essentially did an identical experiment in each state where we randomized their uninsured people to 4 treatments, sent them a postcard and a follow-up email, and we measured whether they clicked on the email and whether they actually enrolled in health insurance. And we'll show you some differences by state. But one reason we were able to work with these two partners is they had a mechanism under state law that allowed them to know who was uninsured in their state. And this is because they have a tax form where people are supposed to check a box if they're uninsured. So that creates the denominator for us to then study out of that database. Turns out most states don't even have that functionality of knowing who's uninsured in their states. So that would be another sort of infrastructure to build to do this sort of work. So looking at our 2 state partners, you can see some slightly different characteristics. They both created this data set of who's uninsured, one in 2020, one in 2019. Colorado has a much larger population of uninsured folks, both because they have a larger population and they have a larger uninsurance rate. And so we were somewhat limited by budget. So when you can't afford to send somebody something, they go into your control group. But fortunately, that still produces useful data for our statistical analysis. So that's why the control groups are different sizes. Of course, we account for that in the analysis. Interestingly, the 2 states have different levels of enrollment at the baseline, aside from their contact. Based on some administrative difficulties in Colorado, we actually sent the email and mailer from DePaul University, whereas Maryland was able to send it for us. We used the same vendor in both cases, but one interesting difference also is that in Maryland, we're able to see whether people enrolled in Medicaid. In Colorado, we're not. You can see very different Hispanic populations, which for the reasons I showed you earlier, that might be interesting if you're especially for Spanish speakers. Different uninsurance rates. And interestingly, slightly different politics too. Maryland is a more progressive state in terms of, say, Biden vote share. And again, if you think this is a moral framing, that might be relevant as well, how people are thinking. Okay, so here's an example of one of the postcards that we sent. We weren't able to distinguish English versus Spanish, so we're sending bilingual postcards to everyone, so they'll read whichever they prefer to read. You can see we use this identical photo of clip art. One of the states, I think Maryland, picked this clip art and the coloration. We had some debates about what that means or who it would appeal to, but it's doing this sort of field work, you sometimes take what you can get. Here's the responsibility framing. It's your responsibility to get covered. These came straight out of our Google ads. And then here's one about a sort of community benefit. An insured community is a protected community. Enroll now. So here's an example of our email copy. Find a low-cost health plan today was consistent for everybody. But this is a status quo message, can protect you and your wallet from the unexpected. This is that sort of rational actor model. Okay, so we're excited. You're just one of a few preliminary groups to see this data before it's peer reviewed, before we're actually done even kicking the tires statistically. Anything to add before we dive into that, Wendy? Or maybe you should lead us through this, please.
Yeah, I mean, I was just thinking there's one other thing we might want to add to the slide comparing Maryland and Colorado, which is that it was originally our intention that the postcards and the emails would go out on the same date in both states, obviously during the open enrollment period, but due to some administrative hurdles, the Colorado postcards and emails ended up going out, much closer to the end of the open enrollment period than when Maryland's went out, because as you're about to see, our results between the two states are quite different. And so one of the things we're trying to do is better understand what might be driving the different results between the two states. So that was just the only thing I was thinking as you were presenting that we may want to add. I also actually think, though, that the fact that the postcards went out with a return address of DePaul University and without the name of the exchange, it said, it directed people to Colorado's exchange website, but we weren't allowed to use the branding for the Colorado exchange. And then the email also came from a DePaul email address. So I'm, wondering to what extent that also impacts our results. But yeah, we can jump into it, Chris, if you want to flip the slide. Do I have access? No, I think you have to do it. Okay, so the first thing that we wanted to look at is just to kind of compare how people's click-through rates on the email, sort of like we had done in the prior phase of the study where we were looking at click-through rates based on those Google ads. And what's sort of interesting is that the Maryland data, particularly if you consider that we aren't able to distinguish between the Spanish speakers and the English speakers, is pretty consistent with what we saw in the Google ad study. So the responsibility message, it was the most popular in terms of click-through rates, and then affordability and community were pretty consistent. But Colorado, you can see, both has lower click-through rates overall, and also a different order of popularity. So the affordability messages there were the most popular. Okay, so we set these up as essentially two separate studies. We randomized separately in Maryland versus Colorado, and then the results are fairly significantly different between Maryland and Colorado. So we're going to run through the results for each of the states separately. And as Chris noted at the beginning, one of the key differences too, as we're thinking about these results, is that for Maryland, we have data on enrollment in Medicaid in addition to enrollment in a qualified health plan, which is the exchange plans. Whereas in Colorado, so far, we only have data on enrollment in a qualified health plan. We're still trying to get Medicaid data there, but we were actually talking about this before we jumped on the public call, but in Colorado, the Medicaid agency and the exchange are walled off from each other. They can't share data with each other. So I'm just looking at the question. Could you use the CMS enrollment snapshots and PUF data by state to see enrollment at different times during open enrollment? I'm not sure I totally follow. Do you follow that, Chris?
I'm on mute, but let's follow up and get more from Laura afterwards.
I'm sorry. No, you were talking about how it might have been different in the two states because the timing during open enrollment was different. So this could help you standardize those responses based on the number of people enrolling at the different points in open enrollment.
Got it. So I actually think we do have enrollment date already for the Maryland data, but I'm not sure I think we have not been able to get enrollment date for the Colorado data. So we certainly could dig into that a little bit more. That's a good point.
Yeah, I was just trying to help more than challenge you. I'm sorry to interrupt your presentation.
we appreciate all help and challenge.
Really helpful, yeah.
It's very helpful to us. Okay, so we're just looking at some of the summary statistics now. This is just raw data before we run any of our regressions. And you can see that all of the interventions in Maryland, this is Maryland data only, saw higher rates of enrollment. Wait, sorry, I'm looking at the wrong thing here. Than the control, which was not sending any individual communication, right? So that's like exactly what we would expect. You wouldn't think that if you sent somebody a postcard and an email and said, hey, sign up for health insurance, that they would sign up at a lower rate. So regardless of the message, sending these communications prompted people to enroll. Affordability did the best for the QHPs, but both responsibility and community performed better overall when we look at any plan enrollment. And in part, that's because it seems like Medicaid enrollment was actually suppressed by the affordability message, although it's not statistically significant. Switch the slide, Chris. Thank you. So now, we are looking at the regression analysis for Maryland. And because the experiment was randomized, the regression basically shows the same story here. I think one of the major takeaways is simply just reaching out to uninsured folks and, trying to convince them to enroll regardless of what the message is, was significant in prompting enrollment. Although you can see that, again, enrolling in the QHP, affordability was the most effective. And then, Chris, if you can just click it. I wanted to mention that effect, the fact that affordability was the most effective message in terms of prompting enrollment in a QHP was driven by the higher income zip codes, which I think is really interesting. And then you can see the data there on enrolling in any plan, sort of consistent with what we've been discussing. Flip to the next one. Okay, so this is the same sort of plot that we looked at in the last phase of the experiment. And you can see this coefficient plot. Again, the red line represents the control. And again, here we're using zip level characteristics. So what this means is that the Maryland Exchange was not able to tell us, hey, for this person who enrolled, like this was their specific demographic characteristics, but we were able to pull the demographic characteristics at a zip code level, trying to see if we see any trends, right? Trying to see if anything jumped out at us as driving these results. And again, there's sort of not much here. We have more work we want to do here. Other things that we might want to look at in a future project. We would also love to be able to get individual level demographic data, but you can see, ideally we want to still dig into age and politics and language spoken at the zip code level to see if any of those characteristics might be driving these results. Chris,
I will just highlight that fifth row that says income below FPL low. So that's actually the richer zip codes that have a low group of people below the poverty level, a small group. And you can see that's where all the effectiveness is happening. It's people that have money to spend. And then when they receive our marketing, they actually do tend to be more likely to buy health insurance accordingly. So that makes a lot of sense, right? This is targeting that 26% of people that it is apparently affordable, as shown by their behavior, frankly.
Okay. So I think let's move on to unless you have anything about this, Chris, move on to yeah. So one of the things that we were interested in was, this is a relatively, easy to execute, low cost intervention. As we said, we're really just changing the messaging and existing marketing that they may already be doing. So we did a little back of the envelope math here. We spent about $10,000 on postcards in Maryland. There was no additional cost for the emails for about 12,500 households. And the effect of the intervention is about 1%. So that means that an additional 125 households signed up for at least one health insurance enrollment with these interventions than the control group that didn't receive any messages at all. And so what that suggests is that the campaign yields a marginal household enrollment per $80 spent. We can spend $80 on postcards and emails, and we can prompt at least one person in a household to enroll in a health insurance policy. Okay, so Colorado enrollment data now. We're looking now again at the summary statistics. So this is just the raw data. One of the things to note here is that the percentage, the enrolling in a qualified health plan is overall much lower than the percentages were for Maryland. So Maryland's, ranged from like 3 to 6% here. The control is about 1% of people are enrolling in health insurance. And you can see just, from the raw data alone that, even when they received a postcard and an email, whether it had affordability messaging, responsibility messaging, or community messaging, these rates are not significantly higher. And in fact, the responsibility messaging is lower than the control, which is weird, right? I said earlier that we would expect that if we were sending this additional marketing that, it would at least prompt some people to enroll in a health insurance policy. And we're kind of oddly finding that with these folks that receive this responsibility messaging, and maybe this is an important finding, although it ends up, you'll see on the next slide, not being statistically significant, but they were less likely to enroll in a policy than those that didn't get any card at all.
Have you guys done any work on the covariates of that, or what might be driving it? Because it does seem not only odd, but like maybe there's groups of people who are already being told you're irresponsible, and so now that we're telling you need to be more responsible, they sort of they react negatively to that, like we're being scolded, or like, do you have a story?
It's certainly possible. That was a concern. You know, the responsibility messaging was a concern of Colorado in particular, wanting to make sure it didn't sound like we were shaming people or anything like that. We were actually like really careful with the messaging to avoid any sort of like language that suggested shaming, although it still could have been perceived that way. But it's strange that it's so different from the Maryland results because we use identical messaging in both jurisdictions. So you would think that if there was, you know, there may be something about the characteristics of the people in Colorado that received these postcards and these emails that made them react more negatively to the responsibility messaging than the people that received those postcards in Maryland. But we're still digging into that. I don't, Chris, do you want to add anything there?
No, I just emphasize that it is truly a null effect. It's not the responsibility, the significance of it. We can't say responsibility hurt anything because these are all non-significant coefficients, but we're still confused as to why marketing to people didn't help by any message.
Yeah, that's fair. I mean, directionally, right, we have a negative on responsibility, but we have no statistical significance, so we can't tell that it's meaningfully different from the control or any of the other messages.
We don't have confidence intervals shown here, but look at that number of observations, 128,000 observations. So it's a pretty tight null as well.
I saw a hand raised, but I think we're almost at the end. So what do you prefer, Peter? Just go to the
no,
end
it's
and then
completely up to you. Whatever you think would be helpful. You can take questions now, or I just jumped in.
raise their hand in case the question is about this slide in particular. Why don't you jump in and ask the question? We'll do that now.
Thanks. And you might have shared this early on, and I think I was a little late in coming on, but in sending out the postcards and sending out the tests and recognizing when or monitoring when people sign up for qualified QHP, are you taking into affect the fact that people have already signed up for a QHP? So you mentioned that Colorado's postcards were sent closer to the end of the open enrollment period. Are you taking into consideration that because they've already been marketed throughout the beginning and middle portion of the open enrollment period, they've already signed up for the QHP? So by the time they received your postcard, there really wasn't a larger population of people who would have signed up for the QHP anyway. Is that being taken into consideration?
That's a great question. It's in consideration, but we don't have any way to explore it empirically as of now, except maybe back of the envelope, looking at the sort of curve of people buying during open enrollment. So it's a great point, and I can't tell you how stressed out we were trying to get those postcards and emails out on time. We thought we had crossed every T and dotted every I 6 months prior, but turns out we had the agency wanted us to do more T crossing and I dotting. So yeah, that's the question we're left with. But we should explore it further as far as we can.
The other thing that I want to mention about the difference in the data between Maryland and Colorado that great question prompted is that because of this walling off between Medicaid and the exchange plans in Colorado, there may have been people, and in fact, they estimate that maybe 20 to 30% of the people that checked that box actually had Medicaid coverage at the time that we sent them the postcard. They couldn't cross-check their list of box checkers against the Medicaid enrollment data, whereas in Maryland, they could do that. And when you talk to the folks in Colorado, they have this guess that there are a lot of people who are enrolled in Medicaid who don't even understand that they're enrolled in Medicaid and may have like mistakenly checked this box. So this is, again, something we're still kind of trying to push on, and we would love to be able to have the Medicaid agency run this contact list through their database and let us know, like, were there people on this list that were already insured? Now, it should be, sort of evenly distributed between our different interventions because it was a randomized study, but I think it would still be good information to know. Chris, I don't really know what to say about, about this particular slide because again, we were sort of hoping that there'd be characteristics that would jump out as sort of driving the effects. You can see on the zip codes that have a low share of Hispanic population, and that is kind of weird, right? The community messaging seemed to be less effective than the control. Whereas in our advertising study, at least among Spanish speakers, which I realize is something different than than being Hispanic, but that message was the most effective. So, sort of hard to know what to make of this.
Yeah, and you can see that confidence interval is huge on that row. We're using a national baseline for what constitutes a low share of Hispanics. We maybe should adjust that to use Colorado specific. Also, while we're looking at this slide, I'll just highlight in that first row how tiny those confidence intervals are, just showing that assistical power. So we really do have a tight null for responsibility and community.
It's because the rates of enrollment were so low.
Yeah.
We did have a large sample size.
So we are done. I see Peter might have another comment. And
I've got a million questions for you, but I'm going to leave room for other people too. But let me just start with one, which is, it occurred to me that community is, a contentious thing, and you don't really, you control for Hispanic percent in the community, but you might think that in a more heterogeneous community, appeals to community might be less effective because, well, racism, I want to protect my community, but I don't define everybody in my zip code as my community. So now you're telling me I have to help my community, but I can't do that. I'm helping everybody in ways that I don't want to do. I only want to help certain people who are like me. So is there any way of getting more fine-grained demographic data about who people think their community is or who their community might be, so that you could see whether appeals to community resonate differently, say in an all-white zip code or an all-black zip code or a mixed race zip code that might, shed some light on that?
You sound exactly like one of our respondents from our focus groups, actually. No, it's great. I mean, in that it's validating. The respondent said, like, my community is my church. So are you telling me I can get them insured? and we're like, well, I mean, we could try that marketing message, but probably that's not a Google ad study. That's some sort of. And by the way, other people have been exploring using religious-based and affinity group marketing of health insurance navigators and things like that. So micro community might be better exploited by those other marketing approaches than what we're doing here.
We actually, one of the goals of the focus groups was to dig into like what language we wanted to use when we actually did the postcards and the emails. And so we asked a series of questions to see what people's reactions were to, helping your community versus helping specifically your church or your synagogue or your mosque. And then we asked people, what about just helping your friends and family? And so we're sort of trying to suss out what was the most popular, what resonated the most with people. And, Chris is right. There were certainly some respondents who said, I really want to help my narrow segment of people that I consider my community. But overall, people said, they seem to like the community message better than the narrower segments that we went down to. And some of them said things like, I don't want to just help my friends and family. Like, that's a very selfish thing. I want to help, my broader community. So I think there's still a lot more that we need to suss out and explore in that.
Great. Well, the floor is open if anybody wants to ask another question. I've got a million more. So, okay, here's Cynthia Cisneros. Go ahead. That's in the chat, so you guys can look at that. She's asking about Medicaid.
Yeah, Medicaid unwinding. Obviously, everybody's very concerned about Medicaid unwinding. I assume this group knows what's going on, but for the first time since the public health emergency started, states are now able to start reassessing whether or not people still qualify for Medicaid, and the estimates are quite high that lots of people are actually going to lose their Medicaid coverage. And depending on the state, they have good mechanisms set up to try to take these people that are losing their Medicaid coverage and move them into exchange plans or other types of insurance. And some states sort of have no plans whatsoever what to do with this Medicaid unwinding population. I think we see the relevance of Medicaid unwinding to our work as just being that, well, now we have so many more people who are about to become uninsured, and so now is the time to market to them and to message to them, and what should that message be? And we're sort of interested in the fact that the affordability message did particularly poorly with the Medicaid enrollments in Maryland. So now is the time for Chris and I to be getting on the phones with the exchanges and seeing if we can, kind of motivate some of what that marketing is going to look like.
Great. Walter is next. Walter, you're muted. Sorry, you got to turn your microphone on. Walter, we can't hear you.
There we are. I'm setting the world's record for the slowest time between the go and the actual get to the unmute button, You know how that works. If you're driving in New York, you can measure the time between when the light turns green and the guy behind you honks his horn. It's very short. So you can hear me now. This is just really a comment about my experiences, not so much with health insurance, although I work for a company that market it, and then you're using an employer to get the message out to people, which is a way you get. And my experience was so much with retirement plans that we tried all these different messages to get people to like, whether it was for their personal responsibility, their family, those messages are all good. We would put people in a room, new employees or groups of employees who are fairly new to the company. They would all sit and listen to, and we had used a variety of messages. As you know this, you use, oral presentation, all a different variety of messages. You could get 90% of them to say yes and walk out of the room. The trouble is when they went back to their office, they didn't actually sign the form and enroll. So what we ended up doing was sort of standing at the door and trying to collect as they went out. So the enrollment piece, and you're not working on that so much now, but getting people to actually act is really hard. And of course, for retirement savings plan, Congress put in an auto enrollment, so then you had to opt out. And I don't think we're not there on health insurance, and I'm not sure how you do it. But the issue of getting people to they can say yes, I would love to travel to China, but they don't actually go, or they want to be in the savings plan, or they want health insurance, but getting them to do it is the trick.
That's so important. Scholars call that the intention action gap, right? And a lot of contemporary behavioral science is trying to use choice architecture to reduce the gap. And as you suggested, a default rule is where you're just automatically enrolled. You can opt out is the most complete version of that.
But it's really helpful to see how you're looking at different ways to get people to think about this, because I think there are a variety of ways to think about especially with health insurance, because it's much harder than a retirement plan.
What's interesting on auto enrollment, though, Walter, is that we do actually do some auto enrollment, surprisingly, in the health space. So the exchanges automatically re-enroll people in year 2 into the same plan again. So, and we've seen that it's hugely sticky, that, people generally, they of course have the right to opt out, but they generally stick with whatever they're re-enrolled into. Yeah. And I just recently learned, kind of back to the last topic on Medicaid unwinding, that Rhode Island is implementing this really interesting project or policy where they are going to automatically enroll people that have been kicked off of Medicaid into an exchange plan with the right to opt out. Now, of course, they have to pay premiums, as you said, like getting them to actually, sort of sign up and do something active, because California wants to do the same thing, but they won't automatically enroll you unless you also, opt in to paying the premium. Rhode Island says we're gonna give you 3 months free, essentially, and then you have to start paying your premiums. And if you don't pay your premiums, then you'll lose your insurance. So there is some experimenting with that. I'm really interested to follow that and see how it goes.
Thanks.
And Wendy, Rhode Island is one of the states that has a mandate as well, right? So
I think that's right.
I mean, it's interesting when you think about these different order of operation, which policy.
Mandates are a lot stronger than an opt-in.
It's kind of weird that it's if you're forced to do it, then making people pay to have it is just a corollary, right?
But I think the messaging is very important for for the long term for health, to get the right message that people will respond to.
Yeah.
We're just really unsophisticated about that in the healthcare industry. When you think about how good marketing is and how much data all of these companies have, it's strange that in healthcare you saw that there was such a uniform approach to marketing based on this affordability theme. So I think any experimentation is probably really useful.
Can I ask you a question about magnitudes? So if you're telling me, I mean, I'm just going to reveal that like the nerdiness that I naturally have. But if you're telling me, oh, your community will be helped if you enroll in insurance, or others will be responsible if you get sick and you don't have insurance. Somewhere in the back of my mind, I'm going to be asking something like, well, yeah, okay, I sign up and then I'm going to be part of a pool. And because I'm relatively healthy, I'll lower the rates for the people that are already in the pool. But that effect is going to be vanishingly small. It's one thing to say, here's $500 to, I can quantify that. Like, here's a $500 subsidy for me. But if you try to explain to people how much their community really would benefit as like a pocketbook issue from their decision to enroll, it's going to be, to a first approximation, zero for any individual person, right? So I guess that makes me wonder what's going on. Do you just have some story about, in the back of your deep unconscious behavioral whatever rodent brain, there's some, like, it just triggers community. I like community, so that's it. Like, I'm not thinking any analytic way forward. It's just like, okay, yeah, community, I like that. So click. That's basically the story?
I mean, let me say that thank goodness the world isn't populated just by law professors like us three, right? So we are a hyper-rational group that would think about the marginal effect of us taking a behavior. Many consumers are not. Really, your point almost proves too much, right? Because all altruistic behavior suffers from this problem of Zeno's paradox. Like one drop of sand or one bit of sand doesn't really make a difference. But we know people do donate to charities to serve the environment or cure cancer or feed kids in Africa. And so people somehow psychologically overcome that feeling of futility, right? But we actually didn't present this slide for time, but we have a slide also about how this sort of moral marketing exists in lots of domains too, whether it's is it what's the shoe company or the sock company? Bombas socks.
Yeah, Bombas.
Give one. There's a shoe one called, is it Todd's? Tom's. You got even wine companies and a range of people say, buy from us because we are a good company, and buying, expresses your values. So I do think it's not, it's often more an expressive function. I'm doing this because it reflects who I want to be or the identity I have, more than on the margin, I will save one life, right?
Yeah, but the socks is a good example, because I can say, well, if I buy a pair of socks, I'm going to give somebody else a pair of socks. Sure. If you ask me, if I sign up for health insurance, how much do I lower the premiums for any other person? It's zero. Sure. So yeah, I mean, I get your point, and thank goodness the world isn't all economists like me. But but there is something weird about the whole thing, and it's also maybe there's not enough time, but are you a little surprised? Like, I would have thought the basic story would be somebody sends me an ad and I say, oh, health insurance. Oh yeah, that seems like a kind of good thing. I'm not really paying attention to the framing of, is this community versus responsibility? Apparently, I mean, obviously your results show that really matters, but were you surprised by that? It's kind of like, why isn't that second order somehow?
I think the point is partly that it's on the margin. So all those other concerns you have also exist, but if we can add, just a little nudge in a direction, if we have a big enough sample, we can detect it, and it might be enough to be worth doing from a policy perspective. So it doesn't negate all those other considerations you have, but it does seem to move people on the margin. But yeah, it's surprising. That's why the project's so fun. And it's also, on the other hand, why we see places like Colorado being like, well, okay, maybe if we're not confounded by the late dates or the inability to see Medicaid data or the other problems with that sample, it is a tonic, right? It is well, once we go to the real world, it's not all roses.
And I think it's important to note that, we're not suggesting that all affordability messaging or anything like that should go away and we should switch to just messages of social solidarity. And one of the goals of the project was to figure out how to target the messaging to the right audiences so that you overall prompt the highest possible levels of enrollment. Obviously, the affordability messaging is working for lots of people. And also we have seen, despite what our pilot results suggested about the additional subsidies, we know the Biden administration's additional subsidies that came out during the pandemic have prompted, lots of people to sign up for insurance. So it's like sort of very heterogeneous across the population of people who are uninsured, and trying to figure out how to target it appropriately, I think, is really important.
Right, and that's, I mean, it seems like Google, for example, is just obviously doing this at a super, super high level, where they have all this A/B testing and they can figure out, everything about you and tailor the ad exactly to you. So maybe the real problem is institutional. Like if we had great marketing people working for the health exchanges in Colorado and Maryland and other places, they would be figuring this out too. It's just that those people are expensive and the bureaucracy is slow, and they don't want to work for a health insurance when they can work for Google or something like that. I don't know, but it seems like there's a lot more that you guys could do, which is good.
Well, it also really begs the question of whether having the government as the marketer is ideal, and whether we could find other ways to align incentives for the private market to get people insured. If we're not going to go down the road of just insuring everybody with Medicare, then maybe we should make sure we're at least exploiting the market where it is useful.
Could you hire advertising agencies and pay them for each person that they got to sign up? Like that would give them a pretty good incentive to try to design the right ads.
Definitely thinking like an economist now.
I'm afraid so, but
and that's the way Google was actually paid on our little experiment. The more clicks they got, the more money they got.
Mm-hmm.
We had a fixed budget anyway, so we're going to use it all anyway, but that's at least the microstructure.
Cool. Well, it's now after 5, so I think we should probably call the proceedings formally to a halt. If anybody wants to stick around, are you guys free for a little bit longer?
Yeah, and always love to get people on Twitter or email. Feel free to follow up too.
Great. I have a few suggestions I'm going to send you in an email. But thank you all for coming. See you in the fall.
Thank you.
Bye-bye. Thank you guys so much for a fabulous talk, and incredibly policy relevant. And I hope a lot of people who control things are listening so that they can start doing all the stuff that you're recommending them to do.
Thanks, Peter. Our pleasure.
Thank you. Bye.
All right. Well, it looks like everyone's leaving, so bye. Thanks again for coming. See you in real life sometime soon, I hope.
Hope so, yeah.
Did it.
Okay, bye.